Dr. Sriharsha Ajjur, consultant urologist practicing in Bangalore. Today I am showing nBlock HoLEP with early apical liberation. This patient had right side kidney stone along with prostate enlargement. First we finished RARS on the right side, we put the stent, and now we are proceeding with HoLEP. It's an nBlock procedure. First I will start with release of the apical mucosa. First I will release the mucosa lateral to the verumentanum. This is the thinnest layer of that mucosa, and as soon as we open the mucosa, we directly enter into the plane between prostate lobe and capsule. Here you can clearly appreciate the capsule and lobe, lateral lobe. Just we proceed, as soon as we identify correct plane, we proceed little bit. So here you can clearly see how nicely it is getting separated without any mechanical push. We can proceed in the correct plane. Now on the right side of the patient, we open the mucosa, and here also you can clearly appreciate how nicely the lobe is getting separated from the capsule. No need of any mechanical push in this area, and we can clearly appreciate the plane. Now I am marking the anterior part of apical limit. Once I mark, I join the mucosa of that apical anterior mark and the posterior dissection. This will completely release the mucosa from the prostate, and when we manipulate the prostate gland, it will not exert any tension on the mucosa. By that way, it will avoid any tension on the sphincter. This will help in gaining early continence. So as soon as you identify the correct plane, as long as you are getting a good plane, you can proceed with the dissection. And now I am cutting the mucosa on the right side of the patient. So as soon as you cut the mucosa, you can clearly appreciate the mucosa moving distally and the prostatic lobe moving proximally. As soon as you get the correct plane, you can proceed in that plane. Create a little bit of plane in the anterior part. Now at the end, we cut the verumentanum from the mucosa over the prostate. Now you can clearly see the plane, and you can proceed with the dissection. So here we need not have to put any pressure. Just cutting the flimsy layer, we can proceed with the dissection. Here the capsule is very thin, so we should be extremely careful while dissecting the capsule from the lobe. It is better to be towards the prostate gland rather than going towards the capsule. You can appreciate capsules of the prostate, and as long as we are in the good plane, continue the dissection. Whatever movement we do now, it won't exert any tension on the sphincter. Always try next to the prostate, always try to be next to the prostate lobe rather than towards the capsule. Sometimes we may enter into the false plane next outside the capsule, so be near to the gland. That will prevent perforations in the capsule. Since we are seeing very good plane, we are proceeding in a posterior aspect. Always have a broader movement. Release the lobe as laterally as possible, and as long as you are getting a good plane, continue in that same plane. Now we are rotating the laser fiber and proceeding with lateral lobe on the left side, on the right side. And most of the time this area is a easier plane to reach the bladder neck. In this patient, capsule is very thin, so we have to be careful during dissection. Should never perforate the capsule and be close to the gland. You can clearly appreciate how the capsule is detaching, how the lobe is detaching from the capsule. So as long as you are in a good plane, just we have to continue there with the broader movements. As long as where we are in a correct plane, the dissection will be smooth. So as soon as we enter a little bit inside the prostatic tissue, we can see the charring. But better to be near to the lobe rather than the capsule. Some places where when patient had early prostatic infection where we may find difficulty while identifying the plane. In that scenario, we have to go where the plane is very good and cut through the tissue in the adhesion area. We are almost reaching the vertical fibers of the bladder neck. So this is the bladder neck fibers. We have to make sure that there should not be any major bleeding from the mucosa here. That will disturb our morcellation. Once we identify the bladder neck, then we can proceed with the dissection. Entering the bladder at 11 o'clock gives certain advantages. One is it is a safe zone where there are no important structures like ureteric orifice or some major blood vessels, so we can enter safely. And once we enter there, we can proceed downwards, making sure that we are not injuring any ureteric orifice, and the plane will be clear. And since we have already dissected posteriorly, joining these two lines give a safe plane and avoids any undermining. So bladder neck will be preserved, and it's easy for us to lift the gland and push inside the bladder. Now our job is to join the lateral dissection area into the posterior dissection area, and same way we are going to dissect on the left side of the patient. So here we have already created a plane and keep dissecting until we reach the bladder neck laterally. If we get any confusion in the plane or where the plane is not good, then we have to move towards the cleaner zone, and from there we should start dissecting towards the confused area. Sometimes anterior dissection becomes difficult. So in that scenario, keep dissecting on the lateral plane, and once we come anterior plane, we have to move the scope little bit distally and identify the apical region properly where we have dissected early, and cut the connection between the prostate lobe and the capsule. That way we can enter the plane easily. We may leave some tissue near the apex. If tissue is more, that we can tackle later, or if we retain some tissue near the apex in the anterior part, should help in retaining more continence. So once we get the correct plane, just keep dissecting towards the bladder neck. Here you can see the capsular fibers. we have to connect the two planes laterally. These mucosal bleeders are the major concern during morcellation. Better to tackle these bleeders during dissection of the bladder neck itself. You can see continuous oozing from the mucosal bleeders. Here I had a doubt of entering into the prostatic tissue. Then I went back and I reconfirmed the correct plane from previous dissection. And once we proceed towards the 5 o'clock position, then we can join these dissection lines from the posterior dissection. This is the most difficult zone in posterior dissection. Here we may undermine the bladder and we can easily go behind the bladder. So for that reason, if you already dissect the lateral part, here we have to just connect the we have to just connect both the dissection lines. Now we can push the prostatic lobe inside the bladder. That will help us for better dissection. And since we already know the lateral limits, chances of undermining or injuring the ureteric orifice becomes lesser. And during this dissection, we can distend the bladder a little bit, close the outlet partially, and distend the bladder. That will push the ureteric orifice a little bit inside, and then we can finish the dissection. We have to be extremely careful in this part of dissection. Risk of undermining, risk of injuring to the ureteric orifice or opening up a major bleeder are very high in this zone. Especially during prior infections, it becomes difficult in this zone. Here you can observe slight pressure may cause capsular perforation and undermining. You can see slight undermining in that zone. Since we are coming from laterally, we can reorient ourselves towards the prostatic lobe and continue the dissection, and thus avoiding any undermining or capsular perforations. See, I am going towards the prostate lobe rather than going into the capsule. These are the mucosal bleeders which create a lot of problem during morcellation if you don't tackle properly. Here the biggest advantage for me is prior degestanting, that I'm sure that I am far away from the ureteric orifice by seeing the stents. Be close to the prostate adenoma as much as possible. Never enter capsule in this area, that can create a lot of complications. Since we have already released the apex, whatever amount of pressure we put on the lobe, it will not affect anything on the sphincter. These are the final fibers of the bladder neck. Here also we should be extremely careful during cutting the fibers. We have to orient ourselves to the ureteric orifice. Better to close the outflow so that bladder will be full and we can finish off the final part. We have to spend adequate time in achieving perfect hemostasis. Major bleeders will be in the bladder neck. These mucosal bleeders are the most important bleeders during our morcellation. So we have to achieve as much as hemostasis by coagulating this mucosal bleeder so that we can get clear field during morcellation. These are all mucosal bleeders which trouble later. And also check for any bleeder in the capsule. Here you can see little bit of undermining during dissection. Here the capsule was very thin. You can appreciate absolute zero bleeding. Some places I am coagulating with just for precaution. We should not coagulate aggressively near the apex. Apical mucosal bleeders eventually will stop. I will reconfirm the ureteric orifices, and once we achieve almost complete hemostasis, now we'll proceed for morcellation.